Hello, this is Dr. Todd Rice. I'm an associate professor of medicine at Vanderbilt University Medical Center in the Division of Allergy, Pulmonary, and Critical Care Medicine. And I'm also the director of the medical ICU for the medical center here. Today we're talking about two studies that we recently published in the New England Journal of Medicine about IV intravenous fluids that we give to patients. So there are two types of what are called isotonic intravenous fluids that we give to patients in medical practice. One is called saline, one is called balanced fluids. And they've been used in practice for over 100 years, but we haven't studied them to the depth to know if one of them is better than the other, or if one of them has bad side effects, or if we should be preferentially using one over the other. So that was the purpose of this study, was to study these two different types of fluids, one called saline, one called balanced fluids, to try and determine the effects of the two in patients. Yeah, so the trial design was a cluster crossover design where we took a unit, the emergency department or the ICUs, depending on which of the studies you're looking at, and for a full month used whatever intravenous fluid was the study fluid for that month in that unit. So the emergency department, for example, for the month of January would have saline as their predominant fluid and the fluid that they were going to use. And then February they would use balanced fluids. And there were a couple reasons for that. One is that we could control the supply, and so that the fluids in the department at that time were all just the study fluids. And the other was that the clinicians knew what fluid was for that month, and they could actually then be better at prescribing that fluid for the patients during that month. Yeah, so lactated ringers is named after Dr. Ringer, who is the person who developed it. So that's why it sort of has this Ringer's name to it. And it's the lactate part. It contains ions, and some of them unmeasured, but measured ions that are different than chloride as an ion. It's specifically lactate instead of chloride to sort of buffer the solution and make it more, the composition more closely resemble that of human plasma. And so, you know, it was really kind of just named after what it contains, which is some lactate, so the lactated part. And then Dr. Ringer is the one that sort of developed it, so it got the name lactated ringers. As there is a little bit of potassium and actually a little bit of calcium in both of those are in lactated ringers. So this was a kind of a companion two-sister, as some people call it, studies. One of them done in patients in the intensive care unit, the other one done in patients that were admitted to the hospital floor, not the ICU, from the emergency department. In the ICU study, the primary endpoint was this composite called Major Adverse Kidney Events at 30 days, or MAKE-30. And that's a composite of developing any of death, new dialysis or renal replacement therapy by day 30, or persistent kidney dysfunction at hospital discharge or day 30. And persistent kidney dysfunction was defined as a doubling of your baseline creatinine that was still double by the time you were either leaving the hospital or dying, essentially. The emergency department study, which enrolled 13,300 patients, the ICU study enrolled 15,800 patients, separate patients, so about 30,000 patients total. The emergency department study had a primary endpoint of hospital-free days, which are essentially days that you're alive and out of the hospital. So it's the inverse of being in the hospital. And a secondary endpoint of the major adverse kidney events at 30 days for the ED study of patients that were admitted to the hospital floor, but not the ICU. In both of the studies, the major adverse kidney event at 30 days endpoint met statistical significance, meaning that there was more death or new renal replacement therapy or persistent kidney dysfunction at 30 days in the patients who received saline compared to those that received lactated ringers. So in the intensive care unit patients, in the critically ill patients, it was both death and dialysis were the two that drove the signal and were the things that were different in the two arms of the study. In the patients that were admitted to the floor from the emergency department, it was mostly increased creatinine and persistent doubling of the creatinine that kind of drove the composite endpoint. Yeah, great question. So numerous studies, including ours, have shown that saline increases the levels of the sodium, increases the levels of the chloride, and actually decreases the levels of bicarb in the blood. And the question has always been, clinically, is that important, and does that cause any problems in the patient? the presumed mechanism, it's not entirely understood, but the presumed mechanism of how chloride may result in these effects in the patient is that chloride causes a constriction of the arterioles that provide blood to the kidney, and that constriction decreases blood flow to the kidney, and from that can cause some kidney damage. Now, it's not entirely clear that that's entirely the mechanism. Others have found that higher chloride also leads to inflammation, and that the inflammation may actually be causing some of these worse outcomes in patients also. This is where we think this is a big deal. The overall signal in the study is not very large, meaning that there was about a 1% difference in the two groups in the outcome of major adverse kidney events. However, from the data that we have from kind of administrative data, there are probably more than this, but at least 30 million people in the United States each year that receive intravenous fluids in the form that we studied, and the vast majority of those actually receive saline. And so if you do 1% of 30 million, you're talking hundreds of thousands of patients that we could be preventing from either dying or developing kidney dysfunction simply by switching the IV fluids. Yeah, good pickup by you. There were a couple things that we're looking into further to understand if we can better characterize which patients are the most risk for these adverse events. One of them is your chloride level above 110 when you come in. The second is if your creatinine is already elevated a little bit when you come in. Both of those seem to identify a subpopulation of patients that seem to have even worse outcomes when saline was given, or even better outcomes compared to saline when balanced fluids were given.